So we've performed the team brief and we're ready to go. All members of the team know exactly what we're going to be doing. And the first thing is obviously venous access. This again is standardised. First of all, I'm already checking to make sure that the CARTO system is set up, and the way that we perform vascular access has already changed from when we started to make this video. Here we're just using standardised anatomical landmarks, but again, as part of a continual improvement and trying to make marginal gains everywhere, we've moved already to ultrasound guided access. You'll see that as soon as I start to try and gain access, the catheters will be passed to my clinical fellow to start getting that set up. We try to make sure that neither of us is not working at any point. Here you can see, just using standard anatomical landmarks in this slim patient, it is easy to gain vascular access. One of the things that should be stated is that the more you analyse your data, the easier it is to analyse individual points and get better at each single step. I view an AF ablation as a number of steps. Right now, I'm expecting that to get from needle to left atrium and start making the map will take less than 10 minutes. If it takes more, I'm aware that the case is probably more difficult, and at that point my mindset and how I approach the case alters, and I take myself out of the standardised process and realise what is different. Here, this is going to be a standardised case with no complications in terms of difficulty. Okay, can I have the table up, please? Straight away, we go with the short sheath for the coronary sinus catheter and two long sheaths, which you can see here, for both the ablation catheter and the mapping catheter. I use a single transeptal puncture and place both catheters through the same hole. If this proves difficult, I will then do a second puncture if required. This is rarely the case. If there's a PFO, I will use that, but if it feels that it will be difficult to perform the case, I will have a low threshold to moving towards a transeptal puncture. Once the coronary sinus catheter has been placed within the coronary sinus, I immediately put the ablation catheter onto the cava tricuspid isthmus. The reason for doing this is the cava tricuspid isthmus is very close to the diaphragm, and therefore there is normally a lot of movement with respiration that the CARTO system is able to pick up on. This means that respiratory gating can be done accurately and quickly whilst I'm getting on with doing the transeptal puncture. As I've said earlier, we do this under transesophageal echocardiographic guidance. This minimises fluoroscopy, and in this case we use 47 seconds of fluoroscopy for the entire case. Normally the fluoroscopy time is less than a minute for all cases. Here you can see that I'm using both fluoroscopy, but mainly the transesophageal echocardiogram, and by doing so I've now done the transeptal puncture safely and efficiently. I'm going to start dilating up the PFO so that I can pass my ablation catheter through the same puncture site. Once you have the wire in the pulmonary vein, it is not necessary to continually use fluoroscopy, especially when using the transesophageal echocardiogram. Heparin is given immediately after vascular access, and we tend to give around 8,000 units. This is then done immediately after the transeptal puncture, aiming for an ACT of above 300 and less than 350. Again, you can see we're now making the CARTO shell. Because the catheters were already respiratory gated, there is no delay there, and as soon as I get across, I can start making the map. If this was a persistent AF case, we'd perform a cardioversion, and then also a pace at 500 milliseconds, as we are doing here. Again, I make the map in a standardized way. I always start off at the left veins, and then go to the right veins, and then I fill in between. I move the same way every time, which helps the CARTO operator work hand in glove with myself. Normally within 10 to 12 minutes, we've made a map which is an accurate anatomical description of the chamber that we're going to work in, and also we'll have at least 1,000 individual data points within the body of the chamber of the left atrium, which is able to tell us voltage information, and therefore whether there's a lot of scar or minimal scar or no scar. Again, we can correlate this with the MRI, and unless there is a huge discrepancy, the lesion set will not change. If the voltage of the left atrium with an upper limit of 0.5 millivolts is normal, we'll be doing a pulmonary vein isolation procedure only, whereas if there is scattered scar or the MRI has suggested scar and there are patches of scar on the voltage map, we'll be doing a pulmonary vein isolation plus box procedure. As I said, we'll only change the strategy from the pre-procedural strategy if there is a gross discrepancy between the voltage map and the pre-assessment MRI.